Pleasure to welcome you all to this special interest group discussion on hepatocellular carcinoma. And it's really heartening to see that the task force on HCC under the chairmanship of Dr. Subrat Acharya has taken great strides in bringing up 3 guidelines on HCC and also organizing these meetings throughout the year as well as during the annual conferences. So without wasting any time, I would like to invite my co-chairperson, Dr. Subrat Acharya and Dr. P.N. Rao to the stage. Okay, and the panelist for this session would be Dr. Jose Debus, Dr. I welcome you to the stage, Dr. P.N. Rao, Dr. Prashant Bhangui, Dr. Sudhamshu Keshi, and Dr. Subrat Acharya. And and Dr. Anand Kulkarni. And here, the first 20 minutes will be presenting a case scenario and we'll be taking opinions from the expert panel. And subsequently, we have 2 presentations that were submitted by our people from all over India and which was selected for this presentation. One is by Dr. Sherin Thomas from ILBS, who will be presenting on the role of PIVCA, and then Dr. Priya Singh from PGI Chandigarh, she will be presenting her work on the role of genome alterations in mast cell HCC. So I would begin with the case. Yeah. So this is a 54-year-old businessman who is he's an obese gentleman with a BMI of 35 kg per meter square and hypertension for 16 years and then type 2 diabetes for 12 years. About 3 years ago, he had some GI symptoms unrelated to liver, and then he visited the gastroenterologist. Their ultrasound at that time showed a grade 3 fatty liver. FibroScan LSM value was 15.4 and a cap of 378. Bilirubin was 1.2, albumin 3.8, AST 50, ALT 40, platelet 40. Platelet was 140,000, and FIB4 at that time was 2.69. So based on these findings, he was suspected to have cirrhosis. He was advised to undergo upper GI endoscopy, but the patient had refused. And he was labeled as MASH-related cirrhosis, and he was told to undergo 6 monthly surveillance with ultrasound and alpha-fetoprotein. And he was told categorically that you have a high risk factor for developing cancer, so you need to undergo this 6 monthly surveillance. And he was very meticulous because he was apprehensive with the word cancer, and he did undergo meticulously 6 monthly screening by ultrasound and AFP. The last screening was done about 4 months back, and it did not show any lesion, and the AFP remained normal throughout. Now he had developed some pain in abdomen, and another gastroenterologist advised a triple phase CT scan of the abdomen. This CT scan of the abdomen on the arterial phase showed multiple diffuse infiltrative type of lesions with enhancement in the arterial phase and some washout in the portal venous phase, and he was labeled as infiltrative HCC, bilobar involvement, no portal vein thrombosis. And mind you that he had been undergoing 6 monthly ultrasound with an AFP measurement, and they were normal. So my questions to the panelists are 3. Did ultrasound and AFP miss the lesions 4 months ago? I would put this question to maybe Dr. Jose. Yeah.
Oh, yeah. Here. Hey, thank you very much for having me. No, he wants me to be further away from here, so to avoid. So the question whether the ultrasound alpha fetoprotein missed a lesion. So there's a couple of things to keep in mind in there. One of them is that ultrasound alpha fetoprotein are not great, right? So they basically the sensitivity is about 65% with both combined. So you're looking at about 30% of HCCs that will be missed in here. So that's very, very possible. Also, this gentleman had, and this is very important, I think, at least to me, I mean, he has a BMI of 35, right? He's an obese patient. We do know that ultrasound in these patients is very difficult, very operator dependent, and even if you have an experienced operator to try to find something is very difficult. Alpha fetoprotein, we use it, and I think it's recommended, but we need to keep in mind that most studies of alpha fetoprotein in HCC have been done in hepatitis C and B. We don't have that many studies on muscle D related HCC, so I don't think, we have to do it anyway, but I don't think it's that sensitive. And so those are 2 points. And the third point that I think is very valid is this is not one mass that you're seeing there that maybe you miss or not. Really, screening is not meant to catch these kind of tumors. They are meant to catch like a single nodule that eventually becomes a cancer. So I think there are multiple reasons why this gentleman did not have had the presentation that he had. Going specifically to your question, could they have missed it? I would say yes, it's a possibility because him being obese, but also it could be that this kind of infiltrative cases can come really quick and really fast. So that's another possibility.
So a corollary question, that you mentioned that the patient has a high BMI, so in which the ultrasound is likely to miss even if it is a nodular HCC because of the obesity and all that. So would you suggest a different approach for surveillance in these patients who have?
That is a great question, and it really depends how you look at it. I think the first answer is, if you're looking at the patient, I would say yes. And we do this sometimes in the US where we alternate between doing an ultrasound and then you do an MRI and then an ultrasound and an MRI. And a lot of practitioners do that. There's no good study showing that works. But I think in this gentleman, it wouldn't be unreasonable to do that. That's for the very personal point of view, right? If you stand off and you look at screening populations, then you really need to wonder where you can do that, because the reason we do ultrasound is because the cost effectiveness of doing ultrasound versus finding a tumor makes sense. When you start adding a whole MRI in there, then things change a little bit. But I think if this gentleman had the means to pay for that, and he was obese and with muscle DH cirrhosis, I probably would have alternated between an MRI and an ultrasound. But I don't think that's guideline related, and I don't think that is something that you must do. I think it's a bit personal between you and the patient.
Okay, so I will take opinion from Dr. Subrat Acharya, because he had done this study in AIMS where he had periodically done CT scans too. So what's your opinion and what has been your experience?
There has been rethinking about the sensitivity has best is 63 to 64%. Second point is suggested visualization score. If you see now American Radiology Association recommendation of imaging, the visualization score is very important when you are doing ultrasound. And the visualization score has been divided into 3. 1, 2, 3, very distinct. Excellent visualization, moderate visualization, and poor visualization. And when there is visualization score is moderate to poor, which is more likely in obese with a fatty liver disease, without a dedicated ultrasonologist. They suggest more frequent or more advanced screening, like abbreviated MR. This has come into the recommendation. Second, if you see ASLD guideline, they have asked to improve screening using further biomarker like adding L3, alpha-fetoprotein L3, which is known as GALAD or GALADA score, where the sensitivity has gone off from 63 to around 80%. So obviously under these circumstances, knowing this fact that this patient is obese, he is diabetic, which are two metabolic risk factors associated with all forms of cancer.
Ashish, can I make it? Here is that, see, our aim is to detect early in any HCC, right? That is the very early detection. The sensitivity of both the ultrasound and the AFP are very limited, about 60% maximum. And the way you do the ultrasound, I think USA, it is already prepared images are seen, the person behind is also important. My question is that at least even if you did, this patient has got an advanced fibrosis already. So he stands at a very high risk. Not going by the guidelines, if you go by our own experiences, I would request every 3 months in this patient because of an advanced this one at a good center. That is again important because we go by only by ultrasound. AFP is very poor again for early detection. My question to or a suggestion, clarification needed is that if you cannot detect that early, at least our aim should be able to detect at least less than the million. At least there is a 5-year survival is good by any modality. So are there any guidelines or anything to say about this? Detection less than 3 centimeters, Milan's criteria, this for surveillance wise,
So we was asking the question, is there any specific tool to detect early HCC, right? In fact, that is the purpose of screening. All purpose of screening is to detect early HCC, because early HCC survival, obviously you can offer curative treatment, whether transplant surgery, and that is the purpose. And that purpose is being defined by the present recommendation of ultrasound and ultrasound. And particularly the disease epidemiology has no more happy and now from this decade earlier, during last decade, the whole disease epidemiology has changed. You are no more seeing Hep B or Hep C. You are seeing all fatty liver disease, all obese patient, all diabetic patient. And from low socioeconomic strata, it is high socioeconomic strata. So in this case, Professor Rao, we should change. And I will request Ashish this portion in the further update in the guideline of INSL should be a special section. And it is time to bring in, remember, Asian Indians, particularly Indians, we are more prone to develop insulin-resistant fatty liver disease with mild weight loss. We are the people who brought in the concept of lean mass. And itself is a problem. So keeping these facts, I think Dr. Rao's point is extremely valid, that it is time, and this SIG should note it, to shift the type, frequency, right, of surveillance from standard ultrasound alpha-fetoprotein to abbreviated MRI, which is not expensive, for example.
Can I just make one additional comment to all the important points that have already been raised by everyone? We also should look at a dynamic screening protocol, as in you start off with an ultrasound and alpha-fetoprotein, and now there is evidence to show that if you have an ultrasound visualization score of C, you may want to shift in that particular individual to an imaging which is based on CT or MRI. And MRI, abbreviated MRI, is probably where we will go to because of the cost implications as well as what we can do as a part of screening. I'll speak about this a little today afternoon in the NAFLD HCC talk that I'm giving. But I think there is a move now already, and that's why we need to incorporate it.
And Prashant will, since you have reviewed, you will also find that in the literature, abbreviated MRI without contrast and with contrast has similar result.
Yeah.
So we don't need a contrast also.
So in the panelists we have also Dr. Anand Kulkarni, Dr. Hari Kumar Nair, Dr. Mitra Prasad, Dr. Suprabhat Giri and Dr. Tarana Gupta. Sorry, I missed them initially. So, so very well, I mean, all these points are well taken, and I would, in the interest of time, I would go here. So this patient was, because of extensive bilobar involvement, he was staged as BCLC B3. So we now label him as inacil BCLC stage B3. And his child function was good, CTP-A 6/15, alpha-fetoprotein was normal, but PIVKA was high, 15,000. Again, based on this current staging, what treatment would you offer? So maybe Dr. Anand can answer.
I missed the alpha-fetoprotein level, sorry.
Normal.
Normal.
PIVKA high.
It is a typical fatty liver disease SCC where alpha-fetoprotein will be
so
normal and
this is
PIVKA will be very
the
high.
CT scan. So
If
based on this treatment, what
no vascular invasion, only
No.
centers with normal AFP you would take up for transplant. But if you ask me what I would do, probably local regional therapy, if feasible, then followed by systemic therapy.
So this is a diffuse infiltrative HCC.
And, then probably systemic therapy directly.
Directly systemic therapy.
But with considering Prashant being
Other
here,
panelists would agree, or do you have a
transplant
difference of opinion?
You remember today, you saw the imaging, right? You see the tumor burden is huge, right? And he has a good liver function. And today I will combine multimodality treatment, right? In this particular patient, if the albumin and platelets, they're fine, his bilirubin is fine, why not giving him, right, a tear, right? And of the tumor, and after the tumor comes down, you have to reassess whether the patient is subjected, can be subjected to further local regional therapy, and with frequently followed by, right, other systemic therapy. I think this person will need multimodality alternative, right? Today Prashant will say any tumor he will transplant. His portal vein is fine, right? He doesn't have extrahepatic metastasis, he doesn't have extrahepatic lymph nodes, right? His pulmonary lungs is fine. Probably he will do a PET or bone scan to see his bones are normal. And he say everything is fine, I will do, right, a transplant. Because any tumor, right, now there's aggressive surgeon are prepared to transplant. So there are two ways to look at it. Third thing is treatment affordability. And fourth thing is treatment acceptance by the patient. These are two important variables. We must consider that. So keeping these four things, you will take a decision. I don't know what Prashant will do.
So if since I have already been put to the line saying that I will transplant anyone, I would not transplant this guy straight away. So I agree with you. I would give this patient multimodality treatment with TARE and in fact add systemic therapy. I am not looking at the alpha fetoprotein here. I'm looking at the PIVKA. The PIVKA is extremely high. It's an infiltrative tumor. One word of caution: in these infiltrative large tumors which are bilobar, the effectiveness of TARE is lower than what you would expect in other
SBRT would be
tumors.
better. SBRT if you want.
Yes. So I would, SBRT again, it's a huge tumor. It's too much tumor load. So I'm not sure whether this tumor load is going to be tackled. So I would seek the opinion of my intervention radiologist, whether he feels that TARE is going to be effective in this. But given that PIVKA, given that it's a, whether it's I don't know, but I think I would give systemic before going for a transplant. I may not wait for downstaging in this patient. I will give him treatment, probably wait for 3 weeks, repeat a PET. If there is no extrahepatic disease, I think you may lose the opportunity later to transplanting. That definitely I would. My aim would be transplant, but I would give systemic before that.
So this staging of NASL also does mention TARE and followed by systemic therapy. So TARE if feasible. So as you rightly pointed out that you will talk to intervention radiologist, and also TARE is an expensive option. So feasibility. So I'll just rush through. So he was started on atezobev and PIVKA levels significantly decreased by 5th cycle. Follow-up CT scan showed progressive decrease in size and devascularization of the nodules, and complete tumor response as per M-RECIST criteria was achieved after 9 cycles. Subsequently, atezobev was continued, but by 11th cycle it started having liver decompensation, and then at that time atezobev was stopped. And he now started requiring frequent admissions for either ascites or hepatic encephalopathy, and MELD score was had worsened to 36 by now. So what should be done next? Any of the panelists can, yeah.
So sir, we can reassess the disease by repeating CT scan as well as, PET scan, whether he has any extrahepatic mets or not. And if he is decompensating, then liver transplant may be considered in this case, and he should be evaluated for that.
Yeah, so I think that's what was done. He was successfully transplanted few days later, but that was after 90 days of a gap was kept between the last dose of atezobev. The explant pathology revealed complete tumor necrosis in 2 persistent avascular nodules with no tumor remnant. No immune cell infiltration was observed. Initial post-transplant immunosuppression consisted of high-dose corticosteroids, tacrolimus, mycophenolate, and L2 antibodies. Post-LT course was marked by numerous post-op complications, multiple infections, CMV infection, hepatic artery stenosis, anastomotic biliary stricture. All these were managed. There was no acute rejection episodes, and the 2 liver biopsies performed 1 and 3 weeks after were okay. And 15 months later, the patient is still in good health, no signs of HCC recurrence, and normal liver tests. So this was the case. Any opinion from the panel, and
the role of PIVKA in transplant setting? I mean, there is no cutoff. Like AFP, we say there is 400, there is 1000. But PIVKA, is there a study saying that this is the value to say that this patient is not eligible for transplant? I am not aware of it.
No, PIVKA probably Prashant will verify. PIVKA probably has not, yes, alpha beta protein has been taken. But now it is time, and because the PIVKA typically goes up in fatty liver disease SCC, and this dichotomy is in fatty liver disease SCC. Now whether the PIVKA and recurrence is having associated will come with time and experience. I think when Prashant will have a lot of these patients, he will tell us whether it is actually an indicator of tumor biology, aggressive tumor biology, besides the existing alpha beta protein, vascular invasion, PET positivity, right, waiting period of time. All this besides all these factors. Whether PIVKA per se is a indicator of tumor biology, that I think time will say.
we already have evidence saying that a combination of alpha-fetoprotein and PIVKA is indicative. We have the Gallad score, although not directly telling you about prognosis. But now for the last, I think, almost 6 years, in all patients whom we are transplanting, we are doing PIVKA2 along with alpha-fetoprotein. And like I told you, I did not look at alpha-fetoprotein there, I looked at PIVKA2. And today it's a guide for us to either give neoadjuvant or to downstage these patients if the levels are high. As far as the cutoff value is concerned, there's some data that's coming out now that for diagnosis or for going ahead for more intensive surveillance, 100 is indicated to be more stringent. Higher level, I think there are some studies which say that 2000 and above tells you that it's an aggressive tumor. But it's more the dynamic change in the PIVKA rather than an absolute value, just like in alpha-fetoprotein, which I think is more important. An absolute cutoff value, alpha-fetoprotein, we know it's more than 1000. PIVKA, till today, to answer your question, we don't know. But I think as data accumulates, we'll know more and more. More importantly, it's important to do PIVKA2. This is without anything, and I think again in our next guidelines, we should stress on this factor.
Okay. Dr. Sudhanshu, are you doing PIVKA in your patients? How are you managing these patients in Nepal?
Yes, we have PIVKA2 available, and in most of the cases now, in especially MSLD, since our experience is that the AFP level is not very high, not much secretory tumor, so it's usual practice to do PIVKA2 along with AFP these days.
Okay. So I think we will have to move to the
Cutoff of a PIVKA is still controversial.
Yes.
Less than 40 is absolutely. We have seen many patients who have got even more than 1000 PIVKA, done MRI and both non-specificity, and we have to be careful in assessing PIVKA. This one. False positives are very many.
Yes. So there has been issues with PIVKA all around India, I think, because maybe your experience is also same.
We assess for 200 normal patients. The value range is somewhere between 100 to 1000, but never it goes beyond 1000 in normal individuals as well. But 1000, that's what I feel, that patients with HCC more than 1000, is be skeptical. It is like if the patient is on warfarin or ecosprin, the values go high.
Yeah,
Very difficult.
That's correct. But anything,
Anil Arora, they have published a paper, more than 200.
That was, we had done.
But you see, that 200 will be also dicey. I think we have to have other biomarkers, even alpha-fetoprotein L3, combining AFA-L3 will be much better, right? Lenis culinaris, which is more than, if it is more than, normally 3% of the total alpha-fetoprotein. If it is more than 10%, and if you add it, that will help make life probably much more easier, which you should get it, I think.
Yeah.
There are two ways to measure this PIVKA. One is, there is Abbott paste, one is Roche paste.
One is Abbott, another is Roche.
The cutoffs are very different.
They actually, their their values are also different, the units.
MA units normally is which is you are using.